All right, today we are diving into two of the most critical hyperglycemic emergencies you'll ever see in medicine. That's diabetic ketoacidosis and hyperosmolar hyperglycemic state. Now, they can look really similar at first glance, but knowing the difference, it isn't just for exams, it is absolutely life-saving. So let's break down how to tell them apart.
So, picture this. Your patient is unresponsive. You know they have diabetes. Is their body completely riddled with acid, or are they so profoundly dehydrated they're shutting down? Your first move, that very first order you give, depends entirely on answering that question, and answering it correctly. The stakes? They really couldn't be any higher.
Okay, so let's get our bearings here. Both DKA and HHS, they're acute, they're life-threatening complications of diabetes. But, and this is a big but, they are not the same thing.
First up, let's talk DKA. The key to understanding this one is right there in the name, ketoacidosis. This is, first and foremost, a problem of acid just building up and accumulating in the body. And trust me, it's a metabolic catastrophe.
You know, DKA has this classic three-part signature. First, you've got high blood sugar, that's hyperglycemia. Second, the blood is just flooded with these things called ketones, that's hyperketonemia. And those two together create the third, and honestly the most dangerous part, metabolic acidosis.
So how in the world does this happen? Well, it all starts with an absolute, or at least a near absolute, lack of insulin. Without any insulin to push glucose into the cells for energy, the body basically thinks it's starving, so it panics. It starts burning fat for fuel like there's no tomorrow. This emergency fat-burning process, called lipolysis, has a really dangerous byproduct. It floods the body with these acidic compounds called ketone bodies.
And the typical patient we see with this has type 1 diabetes. In fact, DKA can be the very first sign that someone even has the disease. But what pushes them over the edge into this crisis? It's almost always some kind of major physiologic stressor, an infection like a UTI or pneumonia, a heart attack, or sometimes it's as simple as missing their insulin doses. The body's demand for insulin just skyrockets and their pancreas just can't keep up.
Okay, now let's switch gears and talk about our second condition, hyperosmolar hyperglycemic state, or HHS. Look, if DKA is the acid problem, then HHS is the dehydration crisis. This whole story is about massive fluid loss.
And just notice the difference in this definition, right? We still have that severe hyperglycemia, but the other big hallmarks are extreme dehydration and hyperosmolar plasma, which basically just means the blood has become dangerously thick and concentrated. This is the crisis we typically see in patients with type 2 diabetes. The starting point here is a relative insulin deficiency. See, patients with HHS have just enough insulin floating around to prevent that massive fat breakdown we saw in DKA. No fat breakdown means no significant ketones and therefore no acidosis. But they don't have enough insulin to control their blood sugar and it just skyrockets. This extreme glucose level literally turns the blood into a thick syrup. As that syrupy blood passes through the kidneys, it acts like a powerful magnet for water, a process called osmotic diuresis, and it pulls just massive amounts of fluid right out of the body, leading to that profound dehydration.
How much fluid are we really talking about here? The total body deficit can be more than 10 liters. 10! That's an almost unimaginable amount of water for a person to lose, and it's exactly why these patients are so critically ill.
Okay, so we know the mechanisms are different. Now let's see how that actually plays out in the lab values. This is where we can really start to tell these two conditions apart with some real certainty. This table just lays it all out so clearly. Look at the glucose. In HHS, it's just astronomically high. We're talking over 600. Now look at the pH. In DKA, it's low, less than 7.3. That's our acidosis. In HHS, it's totally normal. And the ketones, strongly positive in DKA, but basically gone in HHS. And see that huge difference in mental status? The severe coma or seizures you see in HHS are a direct result of that extreme hyperosmolarity and dehydration messing with the brain.
So understanding all these differences isn't just an academic exercise, right? It directly dictates our immediate treatment priorities. Your first move in the emergency room is determined by whether you're fighting an acid problem or a dehydration problem.
So here it is. The bottom line. For DKA, your number one goal is stopping that acid production by giving insulin. For HHS, your absolute first priority is aggressive hydration. You have to pour fluids back into that patient, and fast.
I'm going to say that again because it is the single most important point for managing HHS. Before you even think about reaching for the insulin, you must address that massive fluid deficit. Aggressive fluid replacement is the absolute cornerstone of therapy, period.
So let's put it all together. What are the first critical steps you're going to take? 1. Restore volume. Get those IV fluids running immediately, especially in HHS. 2. Check potassium. Do not start insulin until you know it's safe. 3. Administer insulin to start fixing the underlying metabolic problem. And 4. Monitor everything closely. These patients are incredibly fragile, and their status can change in the blink of an eye. If you walk away with only one single thing from this explainer, let it be this. DKA is an acidosis problem. HHS is a dehydration problem. This simple distinction will guide your thinking and your management every single time. It's that important.